to, before we start, introduce you to our stroke coordinator. I'm not sure if everybody knows Ashley Stewart, and we'll have Ashley introduce our speaker. All right.
All right, so I'm Ashley. This is Peter. He is our Medtronic rep. So he works with Dr. Chodo and Dr. Katniss. Dr. Katniss is the cardiologist that works with the product that Peter's going to be talking a little bit about this. So Peter reached out to me a couple of months ago about this chalk cryptogenic stroke and the link device that's going to be in here, something that I didn't know about previously. So I thought that this would be a good thing to share with the staff.
All right, thank you. So my name is Peter Grassi. I work for Medtronic. Ashley said, thank you for putting this together. So this is a 1-hour continuing education for RNs. It is unbranded, and it's for just therapy awareness and pathway development. So on the back of your booklets is the evaluation form with the certificate. That needs to be filled out, just a bit of paperwork before we start, and given to me at the end of the presentation, and then you will get mailed by Fiedler, which is the corporation that sponsors the CE, the certificate. So that's how that housekeeping works. The booklets that you have are not in PowerPoint slide formation. There's just like a bunch of information. So if you follow the slides along, you could use the booklets as backups for the information. So I just ask if you have any questions, just let me know. We'll just answer them now. But if they are specifically on the product, we're going to have to do that at the end of the presentation after we do a hard stop, just to make the difference for an unbiased CE. So the title of our talk today is Cryptogenic Stroke, Insertable Cardiac Monitors for Atrial Fibrillation Detection and Secondary Stroke Reduction. So like we said, the company that's sponsoring this is Fiedler Enterprises out of California. That's where the CE will be coming from, and Medtronic is putting this together. So our objectives for today are to define cryptogenic stroke, explain the link, see what I did there, between atrial fibrillation and cryptogenic stroke, discuss the guidelines and evidence that support the use of insertable cardiac monitors in patients with cryptogenic stroke. So you'll hear insertable cardiac monitors, loop recorders, ILR, insertable loop recorders, all mean the same thing. We're going to outline the importance of the nurse's role in multidisciplinary approach in the care of patients with cryptogenic stroke, including the use of the cryptogenic stroke care pathway. And we're going to define the long-term monitoring risk reduction strategies behind the use of ICMs for secondary prevention of ischemic stroke, right? Most of these patients already, unfortunately, had an event. They come to the hospital, and we're trying to prevent the second event. So these are some of the causes, comorbidities, things associated with stroke. A lot of here is stuff that you always think of, right? Hypertension, smoking usually pulls out. Some that you don't think of, like medicine. My background is pharmacy, so I'm really into what medicines are causing, preventing, and that kind of stuff. So something that people don't really think of. Every year in the United States, approximately how many people experience a new or recurrent stroke without looking at your booklets? Any guess? I was way off when I guessed this.
30?
1,000?
No, percent. Just doing percentages.
So 10% would be about 380,000, right? Because it's like, what do you got? Close. It is. Oh, it's a build slide. 795. So almost 1 million people, 800,000 people suffering. So what are the types of strokes? So you have your cerebral infarction, which is, think of it as a clot, right? And it could be formed from many different areas of the body. And there's a blockage of an artery in the brain tissue. Your other kind of stroke is your cerebral hemorrhage, and that is just basically a brain bleed, right? Blood vessel pops in your head. This is why I clean my phone daily, so that in case anything happens, it's clean. Stroke as a healthcare. So what's the impact of these events occurring? So we said you have 800,000 new or recurring strokes a year. 87% of them are ischemic. 13% of them are hemorrhagic, so much more to do with the ischemic side. And it is a leading cause of serious long-term disability in the U.S. We're going to have a lot of slides on the further impact of a stroke and what patients, which I'm sure you're already well aware of, cost to the burden of the system and different outcomes that can happen. It's the leading cause of death and long-term disability. It's often more disabling than fatal, right? You usually end up at a rehab center. Leading preventable cause of disability, and we'll go through some of those causes and modifiable factors. The accurate diagnosis of the origin of stroke can be significant when choosing appropriate treatment, right? That's what these ILRs, ICMs do. They help guide diagnosis. They're not providing any therapy, they're just guiding diagnosis. So here are some of those risk factors that we said: high blood pressure, smoking, obesity, medications, heart disease, physical inactivity, stress, alcohol, high blood pressure, diabetes. Most of these modifiable, but living in New York, you're going to have stress, you're going to have alcohol with that, so. I know I do. So here's our scheme for the etiologies of ischemic stroke, and you can see here that approximately a third of them are cryptogenic. And we'll go into the word cryptogenic and how that's defined. And just remember, it's a diagnosis of undiagnosing. So we're kind of ruling out everything else, and when we don't have an answer, we're going to call it cryptogenic. This is what happens, as you know, with the disabilities associated with stroke, hemiparesis. There's, I guess this is a build slide as well. The values did not come out. So the values are in your booklet. I think it's about 26% or something like that. The dependent, what I want to focus on is the dependent and institutionalized. I believe that was around 20-something%. So, yeah, it's long-term effect on these poor patients that, have an event that can't answer why, and then they end up going through the whole rehab process, long-term care facility, nursing homes, and it's really debilitating to not only the person, the patient, the family members, and the care staff as well. So this is taken from Dr. Holtzman's ischemic stroke workup, and basically how you're going to filter through the diagnosis algorithm. If you just focus down the middle, you have an embolic appearing stroke with no history of AF, and it's a multiple foci infarction. If they have a history of AFib, you're going to anticoagulate, obviously. If it's a lacunar infarction with small vessel disease, you kind of already know the origin, so you're just going to use an antiplatelet, right? The most common one, clopidogrel, aspirin. And as you follow the middle, you can do a standard stroke workup, which includes your MRAs, your CTAs, your TEEs, and then based upon that, if that's negative, I would deem them right to the right. For all testing negative, you have yourself a cryptogenic stroke, a stroke of unknown cause. And then we can go through the middle, and that's kind of what, in the rep world, we think of, oh, it's easy, the patient has a cryptogenic stroke. No, in the actual clinical world, you're going through this whole workup to come up with that answer. It's a little bit more involving than just saying, must be cryptogenic stroke. So here's where we define the cryptogenic stroke. It's a stroke of undetermined origin, about 30%, like we said, of all ischemic strokes. Their diagnosis based on exclusion of other causes, right? And the identification of the origin has significant implications for treatment and secondary prevention of chronic stroke.
Hi, sorry.
No worries. There is a test that we are not giving the answers to. You have to get an 80% to get credit. I'm joking. So here's the classifications of cryptogenic stroke, and these trials actually came up with, and the names of cryptogenic stroke based upon them, the TOAST trial being the most widely used. Right now, the hot one is embolic stroke of undetermined source, ESUS. So Dr. Toto was here. He talked about some of the trials that were involved, Navigate ESUS and other things there. But it's basically embolic stroke of undetermined source, right? So we don't know what causes. The patient had either TIA or stroke. It's ischemic part of it, not hemorrhagic. So what's the correlation between cryptogenic stroke and AFib? It's an abnormal, regular, rapid and irregular electrical rhythm in the atria, decreases cardiac output, and may cause palpitations. So basically, I'm not going to give you a whole anatomy physiology lesson, but basically the atria of the heart are fluttering. So they're fibrillating actually, and the blood is just pooling there, and it's prone to clotting, especially in the left atrial appendage. We get clots there, and they get sent directly up from the left side, right? Physician. They all play a very crucial role in the patient care continuum, and I'm glad you guys all made it to this. So it requires system standardization to eliminate variability in process and practice. That's why we have the stroke pathway, and I'm going to give Ashley a whole big tear path of those. a rigorous data-driven approach, continuing education for both clinical staff and the broader community, prevention that goes beyond acute episodic care to long-term risk factor management, and ongoing care, of course. Education from the treatment of the initial event to ambulatory settings. So when you do a diagnostic workup, it's immediate diagnostic studies for the evaluation of all patients with suspected acute ischemic stroke should follow, and these are all things that you do. And you hit them all. Very familiar with all these workups. Here's your cryptogenic stroke pathway. Basically, you have a patient that's been undiagnosed with a cryptogenic stroke, and could the detection of suspected AF impact this patient management? So does the patient already have AF? Or not? So obviously, if it's not going to impact the management, they're not a candidate. If they are, you proceed right down, and you refer to cardiology for insertion of the reveal for an ICM. And then you can talk about the inpatient versus outpatient. For a cryptogenic stroke, there's evidence to warrant to do it as an inpatient. First of all, the patient compliance is taken out the window. Most people have just had a debilitating event, and now you ask them to come back to the hospital 2 or 3 days to get their ICM. You can catch them on the way out and do it. It takes 15 minutes to put it in. And also, DRGs are different for outpatient versus inpatient, specifically in the acute stroke market. So hospitals benefit from the insertion of an inpatient. And basically, the conclusions here, approximately 1/3 of ischemic strokes are deemed to be cryptogenic. The more you look, the more you find. Short to intermediate term cardiac monitoring may not be enough to detect paroxysmal AFib in your cryptogenic stroke patients, and the Crystal AF study was the paramount study that demonstrated superiority of continuous long-term monitoring of cryptogenic stroke patients with an ICM, and establishing a multidisciplinary care pathways to improve patient outcomes by ensuring the best risk reduction strategy to prevent a secondary stroke. Any questions? And then we have a small case study. So we
I
can
have
go.
a question.
Sure.
So, is it indefinitely that they wear them, or is it the 36 months?
So there are different loop recorders on the market. 3 years is the maximum someone lasts, and 2 years is the other maximum. And every patient that I've ever encountered always asks me, how long does this have to stand? And my answer is always, well, that's between you and your neurologist and your cardiologist. If we find what we're looking for, we can take you out and treat you. We could leave it in and treat you just to get a burden of how, if it's getting better or getting worse with time. Or you can just leave it in forever, kind of like a bullet from the war. Just leave it in forever. If the patient's old and frail and you don't want to bring them back to take it out, you can totally stay in there.
And they're just using them post-stroke or not?
No, so there's many other indications for it. Yeah, we'll
Can you
touch on
see
it.
them under the skin?
You can see, you see them under fluoroscopy? Or-
No, can you see it like looking at a patient? Like you can see
No.
fluids and things. It's
No,
deeper.
it's under the skin, but it's,
But you can
It's pretty
palpate
small.
like the pacemaker, right?
yeah, you can
Like a
definitely
pulse
palpitate
rate.
it up. I have a couple to show you guys after, so you can
Okay.
take a look at it.
So are we putting them in here? So we put them
Yes.
in here?
Yes.
Yeah. Who puts them in?
So Dr. Rohan puts them in.
Oh, it's research.
So this is the case study, and then we'll go right into, then I'll just end this. Basically, here's the presentation, 51-year-old woman. Everything's fine, but unfortunately, she had an urgent MRI and intensive care unit for further assessment. Here's her EKG. And then, of course, she undergone an MRI and TEE, and she was on 24-hour telemetry monitoring for negative, and she was negative for arrhythmia. So, of course, she got discharged, and she was discharged on clopidogrel, 75 milligrams. And then 5 weeks after her initial presentation, she developed a recurrence of the unsteadiness and dizziness, and the patient also developed a right-sided headache with nausea and vomiting. Symptoms lasted 2 hours. Patients were admitted to the ICU after an urgent brain MRI. Unfortunately, this is her MRI. I'm not versed enough to break this down, but according to the notes of the slide, it's not so good. The patient underwent extensive additional evaluation, including a workup for coagulability, which was negative. She was discharged on the anticoagulant for that. So she had that second event. So that's what we're trying to prevent. So I'm going to stop the CE. Now we can answer any questions pertaining to the loop recorder. And yes.
That's what I wanted to know, who reads the input data?
So how our device works is It's under the skin, and at night it has a monitor that sleeps by the bedside, and that is programmed to look for the patient during specific hours of the night. The patient does not have to stay next to it all night. Once it grabs that information, it sends it remotely to a monitoring cardiologist. So here that's Dr. Katniss has, CareLink is the website called, and they have preset alerts in the system that will let them know that Peter is a new patient, and then Peter had unfortunately AF yesterday, and this is the time he had it, and this is how long, and that all gets recorded.
So the bedside recorder just captures the data from the day?
Yes, it just takes it out. It's just
So
used for
it's like your
transmission.
Medtronics almost recorder that you put over? I do that.
Yes, so that was the telemetry patch kind of worked the same way. It had the monitor. The monitor works like a cell phone, so anywhere on Earth you can get a cell signal. It's not Wi-Fi, it will send. So if you're anywhere, and it repeats itself for a number of days, actually 14 days of repetition. So that means your patient does not have to be next to it every single night. They could take a couple nights off if they're going away for the weekend and it's a hassle to bring the monitor, don't bring it. When you come back on Monday, Tuesday, I usually tell patients 7 days is the rule of thumb. So if they're going to be away from it for more than 7 days, take it with you. And once they hit that 14-day mark where we're not receiving any information, the doctor will get alerted that says Peter has not transmitted to us in 14 days. Give him a call and see what's going on. So yeah, it's very small. It's less than a AAA battery, and our battery lasts 3 years. So it's up to that. It completely can go through the metal detectors at a hospital, at an airport. So we give you an ID card with the serial number. It's MRI conditional 1.5 and 3.0 Tesla, so that's the best out there. And we also give you a patient symptom marker. So most of the AF patients, 9 out of 10 of them, are not going to feel it. But someone asked me what else we use it for. So syncope is a big one, palpitations is a big one, and that has a lot of symptoms. So patients have this little tiny key fob, and they can press the button on it, hold it to your heart, in 3 seconds it'll beep, and that just marks the recording, because the device is always recording your heart. That's just a way for you to tell the doctors, hey, I felt something, and then they could determine what's sent over. There is a way to do a complete download of the device. You do a manual transmission. We actually put a sticker on our monitor that says sleep near this monitor and do not touch a button unless the doctor tells you. So if the doctor tells you to do a manual transmission, that's basically a full download. You would just press a button on the monitor, pick up the programming head, put it on your heart, and it would download everything and then push it over to the CareLink clinic within an hour. And the doctor can get everything. AF management, and we're talking AF, you can use it for post-ablation and see if the burden's getting worse or getting better. And if a patient wants to come off anticoagulation and the doctor's like, well, I don't know, let's put a link inside and then we can see what their AF burden is.
When you talk about the AF burden, you're talking about the amount of episodes they have within a certain amount of time?
Time, yeah,
Yeah.
time total. So, yeah, and there was a big talk in the cardio world of what is clinically evidence and what's not. 2 minutes of AF, 30 seconds of AF, 5 seconds of AF. So our device will only record in 2-minute blocks. You gotta hit 2 minutes for it. But then we give a whole cardiac burden at the end of 90 days, automatically generated in the program. Yes?
Peter, what kind of complications, it's not that the product isn't one, but what kind of complications should nurses look for status post-insertion?
So infection is number one, but that is still less than 1%. So it's 0.9% in the hospital for infection. It's subcutaneous, so there's just some, ChloraPrep going on and some local Lido, and then it's inserted. And then for closure, it's really up to the clinician, and everyone has their own way of doing it. Usually Dermabond's involved, maybe some steri strips, and then a Tegaderm with a 2x2 on it. And,
So it could be done like an outpatient?
yeah, totally. In fact, possibly in 2019, it's going to be done in an office setting. It doesn't have to be done right here. It could be done Dr. Rohan's office, Dr. Kennedy's office.
Does the rep have to be there?
Doesn't have to be, but we can relocate it. If you remember, the number 1 spot is 45 degrees between the 4th and 5th intercostal. Your number 2 spot will be vertically right there. And for women that are concerned, or large breasts, you can actually go submammary, lateral. So we've done that too. and works out great. I've tested signals I never had signal doing it, so. Except my next one's gonna be bad.
Can they shower, take a bath?
So that's up to nursing. That, you guys, everybody asks me that, or not everybody, but they'll ask me that, and I'd say that's not my department. Talk to the nursing for that. So basically what I've overheard is 24 to 48 hours, keeping it dry, right? And then you can shower after that, and obviously don't touch the pick off the steri strip. So the Dermabond, let that fall off on its own, and then it's up to each clinician how long they don't want it submerged, because infection is number one. I'll pass around a couple, so you'll see that one end of it has like these little prickers on it, and that's there for two reasons. One, so we want fibrous tissue to kind of grow onto it, so it holds it in place. We have a really tight pocket. The tighter, the better, because then you'll get less noise and movement. So the applicator, which has a tunneling tool, sounds terrible, but it's just basically an applicator, is very thin. So the device actually is bigger than it, so it's kind of really snug in there. And the prickers serve also for a way to get it out. So if some doctor has something to grab onto and take it out. Dr. Rohan's fantastic at that.